Good morning, everyone. We're going to get started. So we'll take just a moment for people to get in their seats. All right. Good morning and hi, everyone. Thank you for attending today's session focused on death registration, digitization, and innovation in civil registration processes. My name is Jaleesa Hinkle, and I'm Director for Programs at the CDC Foundation, supporting the Data for Health initiative. Shortly, I will introduce each of our speakers, who will then speak for 10 minutes. If there's time, we'll also allow each speaker 5 minutes for Q&A immediately after their presentation. If we're not able to get to your question right after the presentation, please write it down and hold it for the Q&A session at the end of all 5 presentations. We have a lot of great speakers today, so let's go ahead and get started. Our first presentation will be Can Digitalization Enhance the Timeliness of the Shanghai Death Registration System by Ms. Chen Li from the Shanghai Municipal Center for Disease Control and Prevention. Chen Li is a public health physician who works as a researcher at the Shanghai Municipal Center for Disease Control and Prevention, specializing in mortality surveillance and civil registration and vital statistics. Her work focuses on cause of death data quality, intelligent cause of death assignment, and mortality analysis, with publications in journals such as BMJ Open and Frontiers in Public Health. She has led multiple research projects on death registration systems and contributes to advancing CRVS data accuracy and policy relevant mortality evidence. Our second presentation will be Enhancing Death Registration in Ghana through Technology, Drawing Lessons from Namibia's Death Registration System by Ms. Yvonne Boatema Yaboa. Yvonne Boatema Yaboa is a CRVS practitioner and research enthusiast who has served as Ghana's CRVS mentor for the United Nations Economic Commission for Africa. Her research interest is in social protection, gender equity, and informal economies, with a specific focus on the integration of digital technology into civil registration to foster inclusive national development. Her current work centers on enhancing death registration in Ghana through technology. Our third presentation will be Bridging the Death Notification Registration Gap in Zimbabwe, the feasibility of community and digital approaches to death registration by Mr. Norman Makunika from Midland State University. Norman Makunika is a demography lecturer at Midland State University and a PhD candidate in demography at Chulalongkorn University, specializing in population dynamics, climate change, and health outcomes. He previously served as an intern with the CRVS team at UNSCAP and has over 10 years of experience in health research and system strengthening, with a strong focus on using data to inform policy and improve health and development outcomes. The next presentation will be Digitizing Death Reporting in Zambia, Evaluation of a Mobile-Based Civil Registration System by Ms. Esther Katama from the Data for Health Initiative. Esther Katama is a statistician working under the CDC Foundation with the Data for Health Initiative, focusing on civil registration and vital statistics systems, with a focus on strengthening data quality, analysis, and the use of vital statistics, specifically death and birth registration for public health decision-making. Her work integrates field-based evidence with analytical approaches to improve the completeness, timeliness, and usability of CRVS data in low-resource settings. She has contributed to multi-sectoral initiatives aimed at enhancing mortality surveillance and advancing equity in population data systems. And our final presenter will be Ms. Maina Mateo from the Ministry of Health, who will present on clinicians' utilization of MedTech evolution for death information documentation in the Cook Islands. Maina Mateo is from the Cook Islands, a small Pacific nation with a population of approximately 17,000 people. As a Cook Islander, she is a New Zealand citizen, and she represents her country in regional and international health initiatives. She is currently working at the Ministry of Health as a supervisor for the Health Information System, where she supports the management, analysis, and use of health data to inform decision-making and improve health outcomes, She holds a master's degree in health promotion and a postgraduate diploma in epidemiology, which have strengthened her skills and deepened her commitment to public health. With that, thank you all for your attention, and I'll hand it over to Chen Li for the first presentation.
I'm Chen Lei from Shanghai CDC. Today, I'm like to share my study on whether digitalization can improve the timeliness of death reporting in Shanghai, China. Timely death reporting is very important for public health, as we know. So if reporting is delayed, we may miss early signals of outbreaks, such as like COVID-19. At the same time, real-time data is essential for resource allocation and policy decisions. So also, Shanghai is a city with over 24 million people, and it has become one of the pioneers in modernizing their death registration system in China. So from the workflow, as we can see from the slides, we can see the workflow of online death information exchange and the quality control process in Shanghai. From the offline system and the pure manual medical certification procedure before 2015, then transited to the online reporting system in 2015, and then the full department integration in 2020. So our main objective is very straightforward. We want to evaluate. So this is the workflow as I have showed you in the cohort 1 presentations. And as we can see from, so our we want to evaluate whether digitalization has improved the timeliness of death reporting in Shanghai. We used nervous. We used a quasi-experimental design based on data from 2010 to 2023, covering nearly 1.9 million death records. Timeliness is defined as the number of days between the date of death and the date is reported. And we use two main measures. The first is the interrupted time series analysis to evaluate the police effects. And we also use the negative binomial regression to identify the risk factors such as death year, sex, age, location, cause of death as the delays. So for the results, as we can see from the overall trend, I haven't put in the slides, but the main results shows the median reporting delay dropped from 16 days before digitalization to almost 0 days after 2020. And the 2015 intervention, as we can see the green line, which introduced the online reporting, led to a very immediate improvement. And then the 2020 intervention further improved the system, although the long-term trend slightly declined afterwards, possibly due to the system has already matured. And to the results of NBR results, we used the negative binomial regression to identify predictors of reporting delays. We can see that several demographic and temporal factors were associated with delays. Females have slightly shorter delays, while non-local residents experienced longer delays. We also observed several small seasonal variations across months. As we can see, as I showed in the results, the December showed the least delay because it's the end of the year. And then also we found the place of death showed the strongest impact. The deaths occurring outside hospitals, especially those reported from other provinces, as known as the other provinces out of Shanghai, like other provinces, for example, Anhui or Jiangsu or other other provinces in China. It is experienced substantially longer reporting delays. So that's a very interesting results. And also, the older age groups tended to have shorter delays, while perinatal conditions and some unspecified causes were associated with longer delays, such as neonatal diseases. And this slide highlights the transformative power of digitalization on Shanghai CRVS system. The 2015 milestone transition to an online reporting system proved that standardized digital working flow created a long-lasting institutional accountability, while the 2020 integration of multiple departments also showed immediate gains. The subsequent minor decline suggests that once a system reaches to a high maturity, external factors like for example, COVID-19 pandemic or saturation can impact the reporting speeds. So it requires continuous dynamic evaluation. And to the discussion, these findings suggest that digitalization greatly improved reporting efficiency. However, some bottlenecks still exist. The first is the provincial data sharing is still difficult because there are bureaucracy bottlenecks, and some cases still require complex verification, such as perinatal conditions or perinatal or maternal deaths. And the third, but not the least, vulnerable populations like non-local elderly and infants still face extreme delays. So that's what we need to focus for. And to the last the slides, based on our findings, we suggest three priorities. First, to strengthen the interprovincial data sharing mechanisms, and second, to improve the training and capacity of the community level. That's the basic. And the last, not the least, enhancing collaboration across different sectors, such as CDC and the Bureau department and the household registration department. We should strengthen the collaborations. In conclusion, digitalization has significantly improved timeliness, but the target efforts are still needed to address remaining gaps. So at the end of my slides, I sincerely gratitude to Roman Santon, Gu Zhen, and Chen Lei from White Strategies, and also my colleague Gao Ya from Shanghai CDC, and also sincerely special thanks to the United Nations SCAF, Nicholas, and the CARD initiative, Cohort 1. That's all my slides. Thank you.
All right, great. Thank you so much, Chen. It's really impressive seeing the improvements that digitization supported in China. Are there any questions from the group, from the audience? Also, if anyone online has any questions, please feel free to put those in the chat with your name, and we'll read those in the room as well. Okay. While folks are thinking, those recommendations make sense, and we see a lot of issues, I think, across countries with data sharing and working across sectors. Do you have any specific recommendations or ideas as it relates to data sharing to support the digitization efforts?
Yes. Big data center to and break the bottlenecks between the different facilities. So we should build a data center to gathering all the data and break the bureaucracy limits. That's maybe the most possible solutions. And another I need to mention, because of the regulations that we want to control the rates of infant mortality, the maternal mortality, and the undefined mortality. So their factors will affect the evaluation of our governments. So when we report these factors, it will have a long delay because we need to bargain. So different departments said, "Oh, I don't want to report this because it didn't belong to us." And then the CDC, such as us, we said, "Oh, that's the maternal disease. We should report this." So that's a bargain, and it would affect the reporting effectiveness of the special deaths. Yeah. So we shouldn't consider the factors too much. Don't think it's as a too weight, a lot of weight. Yeah.
Great, thank you. I see a question.
Yeah. I think for ICT applications should not be a problem in China. But as you mentioned earlier, that a lot of these deaths are occurring in Shanghai, but they are from other provinces. So when you combine the statistics, do you combine deaths by place of residence or occurrence?
May I repeat your question? Are you asking about what happened to the other provinces' deaths?
No, when you combine the statistics on death figures, do you combine it by place of occurrence or residence, where they happen or where they came from?
Yeah, we have all considered as the factors, but the slides I didn't show it. I haven't shown it. But from my paper, we found that the places of other provinces have longer reporting delay. Yeah, the deaths of other provinces.
Okay, Dr. Dan.
Okay, thank you for the good presentation. My my question is, I would like to have an idea on what you call timely registration. In how many days? And another one is, did the transition from offline to online increase the completeness of death registration also? This also, we will have an idea on what is happening due to digitalization. Thank you.
Your first question is how I define the effectiveness. So from the slides, we define the 1 day reporting. So if the timely report date, so if the death happened and the reported time, the less less than 1 day, we thought it was reporting timeless. That's the definition. And what's the second question? I don't quite understand.
All right, great. I think we have time for maybe 2 more questions. We can go there and then here, and then we'll wrap it up.
Thank you very much for your presentation. Regarding to factor related to influence the timeline list, do you or have you considered the policy and legal framework as a factor about that? Because maybe if there's any change in policy or legal framework that may affect the timeline list.
Yeah, the policy. So the slide 6, the interventions in 2015 and the 2020 are the two different. We could also thought it's a policy. So in 2015, we have used translated the whole system from offline system manual coding to the online registration and online coding. That's the one policy change. And in 2020, we have built a big gathering of different system operating from Shanghai CDC to big data center to the house registration department and the bureaucration department. They transfer data online, so the data would be quickly transferred. So that's another policy change in 2015 to 2020. And then after 2020, we found the trend hasn't inclined continuously. So we thought maybe it's because of the other factors such as COVID-19, because it enhanced their working staff's overload. So they may be occupied by other things, such as dealing with the COVID-19 things, and they don't have too many efforts to do that, to do their regular work.
Thank you so very much. Dan from Uganda. You make a very interesting observation, and it left me thinking a lot. You said that there were delay due to maturity of the system. So, and that one maybe an ICT person can answer that. And also you said that this delay is affected by external factors, and you mentioned COVID. And I'm trying to understand really, a mature system should be robust, and when you say now when it matures, there are delays, I find it, I don't know how that happens. And I'm just speaking from the point of ignorance as far as ICT is concerned, but maybe someone ICT can help me understand that. I don't know.
Maternal disease, the maternal disease and infant diseases shows more lacks of reporting. Yeah.
I think, is this referring to the slide, particularly around maternal deaths, where because it was a high priority within the government, there were more layers to get it to the final reporting because more programs were interested. Is that correct? Okay, great. All right, thank you. And I saw that there were more questions in the back, so please write those questions down and we can save those for the Q&A at the end of the session. Next, we'll go to Yvonne for her presentation.
Morning, everyone. As I've been introduced, my name is Yvonne, and today I'm presenting to you enhancing death registration in Ghana through technology, drawing lessons from Namibia's death registration system. I would like to acknowledge my co-authors, Dr. Musidi, Lillian, William, the CAT program I was part of cohort 1, ECA and SCAP for making this possible. And so I start with the stark contrasts between Ghana and Namibia. Ghana, over the past 5 years, have made significant strides when it comes to birth registration, but same cannot be said of death. With death registration, our completeness is still below 40%, and we're still struggling with fragmented systems, data residing in silos, and barriers that prevent effective death registration. But if you look at literature, you realize that Namibia is almost near universal death registration completeness. And this happened after they introduced the e-death notification in 2018. And so we realized that involving technology there has made their system work. And so what we tend to do was to look at the pragmatic lessons Ghana can draw from Namibia's death e-notification system to enhance our death registration. And in doing that, we try to look at the factors that hinder death registration, so the structural and the cultural factors. And we also try to analyze what is causing Namibia to improve in terms of their technology and the collaborations that they have. And after doing that, we would extract the things in their system that we can adapt to ours. And so on methodology, we used document review. So looking at CRVS reports and academic literatures, as well as the legal framework for the various countries. And the documents that we used was guided by the Cradles framework. So we evaluated the sources based on the authenticity, the representativeness, and the credibility of the papers. We also adapted the business process maps to kind of look at the bottlenecks and where the leakages are coming from, why we are not getting the results that we needed. So apart from the business process map that we used, the whole study was informed, or we situated the study in the Rose's theory of lesson drawing, which argues that policymakers can transfer lessons, adaptable lessons in contexts that would work and apply to them. And so that is where the study situates. So on the findings, we realized that if you look at the business process maps for each of the countries, for Ghana, the CRVS system or the death registration really lies on the initiation of the bereaved family to start the registration. And so in the event that they don't do it, then we lose the registration. So for example, in health facilities, the health facility or the medical doctor would give the MCCOD, which is a requirement for registration. However, even though they may issue the MCCOD, if there's no incentive to register because there's no insurance or they are not using the death certificates for pension, then we lose out. And this is a country that has almost 70% of people in the informal sector, which has very limited social protection. And so we tend out to lose a lot of them. In terms of the deaths that happen in the communities, we also tend to lose out because the process is cumbersome. And if we look at, if we listen to yesterday's presentation, Constance made a case of where somebody reported a death at a police station and had to be arrested and get bail before they can start the process. And so nobody wants to go through that. And so we tend to also lose out on deaths happening in the communities to register. And then because of also some of the cultural practices that require that burials are done immediately, if the burial is done and there's no need to register because we are not using the certificate for anything, then we lose out. So we don't register. But if you look at Namibia's system, the case is a bit different. So for them, the registration trigger is not dependent on the bereaved family. It is on the state. So where the death occurs or where the death is reported to have occurred, they trigger the notification through the population register system. And their population register is also linked to their statistics system. And so there's that interoperability there. And so when a death occurs, it gets notified and then get registered. But that cannot be said of Ghana. And so you realize that within the two systems, what is actually making the difference is the e-notification, which Ghana does not have. But when you compare the systems also in terms of the legal framework, you realize that Ghana, the Act does not mandate notification. But in Namibia, their Act mandates notification. So as I said earlier, the notification trigger is not dependent on the family as it is in Ghana. In terms of technology, Ghana has a fantastic technology when it comes to the registration of births. But when it comes to the deaths, the portals are not linked and they are kind of fragmented. And so that's what, but Namibia has the fully integrated one, both web and then the mobile e-notification that is linked to their NPRS. And so the outcomes are clear. So the actual death registrations that we are having, it's very low. I said earlier that it's below 40%. So we hover around, the highest we have gone is 38%. So what do we take away from the findings? We see that Ghana's mortality data remains constrained due to bureaucracy and then the absence of the digital notification, as well as the weak coordination amongst the CRVS agencies. And what has worked for Namibia is that they have the mandatory e-notification that is underpinned by their legal reform. And so we are saying that for Ghana, we can re-engineer our processes to require a mandated digital ecosystem. And so what we are recommending is that as of now, the Act does not mandate the notification. And so there can be a revision so that the electronic notification is mandated by the institutions to send the notification to the appropriate agencies, and there should be a strong collaboration amongst the agencies that are involved in civil registration. And we should also be mindful of the fact that the technology they will say that there's no network, but in Ghana we have I think 98% penetration of mobile. So we can rely on the USSD if we are not doing the web. And so what we'll say is that mortality data is, as we have established, is not just an exercise that we should just say that we are collecting data, but it is a prerequisite for development. And so since we have the foundation technology already, we should be able to amend our laws to include the model that will lead to institutional-led automated notification for us to be able to improve our systems. Thank you.
All right, great. You were right on time. So now we can open it up for questions. Yes, Collins.
Yeah, morning everyone. That's a good presentation, and I was excited to see the comparison between the two countries. So what I wanted to learn was that is that I saw where the police in Namibia, the police are triggering notification. So are they triggering it digitally, or are they triggering it manually, where they are filling a form to be submitted somewhere, then digital?
So for them, it's triggered digitally.
So they are given gadgets, the police.
Yes.
Okay, thank you.
All right, great. I see a table question at that table in the middle.
Thank you for a very wonderful presentation. So I assume that because you compare Namibia system and in Ghana, so I assume that the population register in Namibia is already like have full coverage, so that they can do the notification and directly by digital system. But is that also the case in Ghana? So in order to adapt that, do you also already have this the same system on regarding population register? Thank you.
So in terms of population size, Namibia is less. They are not as many as Ghana. But it is a system. It's just so if you look at the business process map, it's almost the same. What Ghana is lacking is the notification, and because of that, we are missing the registration. So if we are notified, so what we can adapt from their system, not the wholesale, as the theory even posits, we can just adapt the part that is working for them. If you look at their system, what has made the difference is the notification, which we don't have.
Okay, great. Other questions? Yeah, we'll go to this table.
Good morning, thank you. My name is Stephen from Zambia. I wanted to get more of your thoughts on the community notification process. I think from the workflow that you presented, from what I got, it appears the process still reverts to family initiated. Then it's when the family interacts with either the health system or indeed any other government system. I don't know about Ghana, but in Zambia, we have quite a significant population that does not interact with either system. So we have situations where deaths occur in the community. Then within a day or two, that person will be buried. So the family in such situations, when they have no impetus to interact with the system, that death goes unregistered. So just your thoughts on how, with this e-notification, and how you could actually bridge that gap in terms of those respondents that do not interact with the system.
Okay, so what Ghana can leverage on is we have a community population register that so we have registers in the communities. And so if we are doing USSD, even in the rural areas, most rural areas, deaths can be notified.
Okay, we have time for maybe 2 more questions. Okay, go ahead.
Thank you for the presentation. I think you have compared the ASIS desired map, ASIS business process maps of the two countries. So have you come up with desired business process maps for your country? So it will be beneficial for your
Yes,
future.
I have, but it's in the paper.
Okay, nice. Thank you.
Yes, so there's a plug to read the paper when it's available for everyone. Okay, any last questions before we move on to the next presentation? Okay, well, we'll have time later for additional questions. Next, we'll go over to Norman. Sorry, Norman.
Good morning. So just like in Ghana or in Uganda, as my colleagues presented on yesterday, in Zimbabwe, we also have a huge gap between death notifications as well as death registration. So together with some of my colleagues at the Midlands State University, we are currently doing a research to try and see interventions that could be done to try and bridge the gap between death notification and death registration. As in Zimbabwe, I believe more than 90% of all deaths are notified, whether they happen in urban areas or in rural areas. However, only a few of those deaths registered because of different challenges that takes place. And yes, only 41% of deaths registered nationally in Zimbabwe, and maybe less than 20% have medically certified causes of death. So with my colleagues, we are currently doing a mixed method approach to try and look at ways that and interventions that could be done and to try and bridge this gap. So we conducted maybe facility and registry audits at 71 health facilities as well as 18 registry offices in Zimbabwe. We tried to conduct interviews with community leaders as well as community members on the acceptability of community initiated death registration. And as a result, we asked questions on the, for example, acceptance of civil registration and vital statistics, different strategies. 82% of community members were of the view that maybe mobile units, registration units to try and strengthen the gap are acceptable. And then 74% of those that we interviewed were of the view that maybe if we are to initiate traditionally led or traditional leaders led reporting mechanisms to try and make sure that all deaths that are notified are registered. And however, there are a number of maybe gaps that we realize Some of these were maybe issues with digital access. There were also issues of staff training challenges, internet connectivity among some of the facilities, the availability of digital infrastructure, as well as like the interoperability between different digital systems. And from the discussion that we had, we realized that maybe we could introduce a community digital registration loop or system in which the community health workers or leaders in the communities, like traditional leaders in the community, maybe will initiate the death registration after they are notified, because in our traditional systems or in our rural systems, each death is reported to the village head. And after reporting it, most of those are never registered to the national system. So we felt that maybe if we are to empower and train the village heads on knowledge on how best they could maybe initiate the death registration, maybe the community health worker will register the death, the village leader will notify, and then after that, maybe together with those at the health facility could initiate the registration and into the system, and then it gets submitted to the district registration system. And however, there were a number of barriers that we identified that were maybe that were affecting the rate at which registrations were okay. And one of the main barrier in rural areas was the distance barrier to the registration office. So with the introduction of maybe village health workers as well as community leaders, that barrier could be reduced, as deaths will be registered in the villages that they okay, or the digital, the village leaders who initiate the registration and maybe submit either it could be a mobile registration system or even a paper-based system in which that they will go and submit the deaths to the village office, and then that will start maybe the death registration initiation. And then there was also a problem of digital infrastructure, in which maybe some of the remote areas in rural areas, there are internet connectivity issues and mobile network connectivity issue that could limit maybe the use of digital registration. So in that case, that could be supplemented with paper registration systems. And there was also need of properly training maybe the community health workers, the nurses in the communities, as well as the community leaders, to properly do, like, properly complete and with knowledge on how to properly fill out and complete the death notification forms. And there was also need maybe for us for educational programs that could educate local leaders on the importance of death registration, so that at least they could lessen the cultural practices that sometimes lessen death registration. So from the research, mobile registration units in the communities at 82% acceptance rate, traditional leaders 74%, digital notification 63%. So that shows that there's a strong potential that maybe community-based initiatives, instead of us relying on the government systems or those that are at district level, community-based initiatives could enable, and increase and or reduce the gap between death registration, death notification, and death registration. And that potentially has a possibility of reducing the lag between the notification of death as well as the time that death is registered. And that, I believe, to some extent will be sustainable, because these community leaders are in the communities, all deaths are reported to them, and even with limited funding, that model could be sustainable, as people would have empowered maybe people in the community on the importance of death registration and how to practically do it and notify the district office, as well as all the verification that's necessary. However, that, I believe, to some extent would depend on a huge digital data integration architecture that maybe community leaders need to be empowered on systems, and systems need to be developed that links maybe the community leaders with the health facilities, and that to some extent will be linked to the national registration systems together with other different data platforms like the DHIS2 and other systems. And we believe that if this is to be done, this will help in some way to reduce maybe the gap between death notification and death registration in Zimbabwe. Thank you.
Thank you. Very interesting, Norman. Any questions from the audience?
Okay, thank you for the presentation. I would like to get clarification to know, you said that 90% of deaths are notified. Do they notify the registrar or they notify somewhere else? Because if the registrar knows that a death has to be registered and the law recommend that the registrar should register that death, I think in Zimbabwe you wouldn't be at 20% of death registration completeness. I need just clarification to know to whom are those deaths notified.
Okay, thank you. So in Zimbabwe, when someone dies, either they die at a health facility or they die at home. When they die at health facility, the is need for a burial order in order for that person to be buried. So that's in a way a notification in which they notify that someone has died, and then a burial order is issued out for them to be buried. And then when a death happens at home, the people notifies the village head of the death. And in some communities, it's a finable offense if someone dies and you take a day or so to notify the village head. They might fine you a goat or something like that. So that is a notified death within the community leadership structure. However, after that notification, nothing happens and it's not recorded anywhere else. So I was of the belief that if we are to utilize those two entry points of notifications and try to find ways in which those could be linked to the formal death registration system, that could maybe lessen the number of lessen the gap between notification and registration, and increase maybe the number of registered deaths in Zimbabwe. Thank you.
Very great. We'll come up here.
Yes, that's a great presentation from Zimbabwe, and I would like to pick my question from what you've just mentioned about utilizing the village elders. And I can see similarities with the majority of civil registration systems on how to leverage those village leaders, because they kind of have something called the village register.
Yes.
So my point is, one, are they supported by the government? Or are they paid by, do they have, like, is the government paying them? Number two, what I've seen from main civil registrations is that the civil registration agency, most of the time, they tend to trust their own registrars than to trust data from the village register. So you're having that challenge. So in Zimbabwe, how have you handled that bit of improving the trust of this data coming from the village registrar, so that the main CR system, they also trust that data and allow it into their system? Because in most systems I've seen, even if the village, they come with those records, they have to pass through the registrar, the ground, then come back to the national system. Thank you.
Okay. Thank you. So in Zimbabwe, the village health, the village heads part of the Ministry of Local Government, and they receive a monthly income or monthly salary from the Ministry of Local Government. And with the Ministry of Legal Affairs, they've already integrated the traditional village court system into their main, in which like local cases that are dealt with at local level can be referred further to the Ministry of Justice system. So I think we could leverage on something like that because they are already trusted to some extent. They are already government workers. They already receive a salary from the government. And I believe that the government to some extent trusts them more than they trust the village health workers to some extent. So we believe that if it's easy, I think with a number of maybe meetings with the government, planning together the government, I believe that is something that the government will be more than willing to roll out because it links the traditional local government practices with the national formal local government practices, and in a way will help strengthen the local-led initiatives and systems. Thank you.
All right, great. We'll go to Stephen and then up to Dan.
Thank you very much for that very interesting presentation. I think I can see how, from a technical standpoint, this proposed approach can actually lead to a significant increase in death notification. But I just wanted to pick your thoughts on what the legal environment is like in Zimbabwe and how that may either interfere or actually help push this along. And I say this because in Zambia, we have quite very, that's the word, challenging laws that have been there for some time. They have a purpose because, I mean, CRVS information has that legal component to it. But in terms of readiness to incorporate technological advances that are bridging such data gaps, there's a conflict. So I wanted just to pick your thoughts on how you're approaching that. Then secondly, I also wanted to find out how you would incorporate cause of death determination within this particular framework.
Okay, thank you. So I'll start, I think, with on question on cause of death determination. We were of the view and that maybe cause of death would empower the nurses in clinics in those areas to be the ones to populate the cause of death. So the village head would work together with the nurses because in most of our communities there is a nurse or there is a clinic that is stationed at a reasonable distance from the community. So we believe that if the nurses are empowered to work together with the village heads, those would help in populating on the aspect of cause of death, whilst the village head will be the authoritative person who then initiate the process, work together with the nurse and make sure that the death is registered. And on the legal entity, I believe Zimbabwe, just like Zambia, we have a number of challenges, and there are a lot of laws that needs to be upgraded so that at least they could empower the village leaders or our chiefs to be able to do that. But however, as of recent, there are some legal frameworks that acknowledge the role of the traditional leader within the country's judicial or legal entities. And to some extent, in the local villages, for example, if you need a commissioner of us to certify your documents or something like that, the village leaders have been empowered to be able to use their stamp to certify certain documents. So to some extent, I believe that though there are still a number of limitations that could be explored and try to see how best their roles could be expanded legally to empower them to be able to do that.
Thank you so much. I like it because there are a lot of similarities in these countries in Africa, especially. And I don't know whether mine was going to be a question or a comment, but I have a problem with our agencies in our governments. They are looking for the perfect situation and not really what works. These systems are already there. Communities trust them. Communities, they trust a village leader than a registrar coming from the district. So why do you think that what you do is more superior than and is going to be trusted by the local communities? Why don't you empower those guys at community level to give you what you want. All they need is simple training. Yes. And giving them some of those forms that you want a stamp on or that you want to use. So I don't know why we're really insisting in our offices at the district and not really going to empower those guys at the local level and really engaging with them, see what works for them and what works for their communities to improve notification. Now, notification to me is really important for many people. I'll give you an example. If village A notifies 20 deaths in 1 week, I am telling you everyone is going to go there and determine the cause of death, what's happening in that village. Which happened to us in Uganda. People died for like 20 people died for like a month, and they didn't know anything until someone went to the district health office and said, there's a problem we are seeing in this village. People are dying, the whole families are dying. They went back, they found there was Ebola. So notification is the starting point. I would want the registration, the CRVS offices to make it simple as possible. Tell all the other departments to do their work. So it wasn't a question, but I think we need to really find of working with these existing systems and infrastructures to improve what we can improve. And then the determination of the issue of getting a certificate, that is a secondary matter to me. I know it is important for a serious person, but I think someone will benefit from that. Thank you so much.
Thank you.
Great, thank you. I think that's a wonderful way to wrap up the session and probably has given a lot of people thoughts that maybe we can bring to that final discussion. We're going to transition next to a presentation about Zimbabwe's neighbor, Zambia, and I'll hand it over to Esther for that.
Good morning, everyone. My name is Esther Katama, and I'll be taking you through the digitization death reporting in Zambia, evaluating a mobile-based civil registration system. So this basically pre-post implementation study that we had in Zambia were to improve notifications. Yeah, so in my introduction, I'm acknowledging my co-authors from CDC and CDC Foundation, Ministry of Health Zambia, University of Zambia, and at large, the DNRPC, which is the Department of National Registration, Passport and Citizenship under the Ministry of Home Affairs. And to wrap it all, to acknowledgement to CDC Foundation and Bloomberg Foundation for the technical and financial support. So I think, as we all know, CRVS systems are essentials for accurate administrative mortality data, and reliable information are key for public health surveillance and policy. And as many LMIC, Zambia is one of those that experience low registration completeness and reporting. And as it is, it's mostly manual paper-based kind of death notifications. And I think the digitization boosts this completeness and accelerates or rather strengthens public health responses. So our objectives was majorly to evaluate e-notification system that we rolled in Zambia, and this was done in 4 provinces, which we consider those that are highly, or rather with high mortality rates, and also done in 16 sites, this including burial sites and health facilities, having 2 or 3 officers, including the NRPC officers and MOH officers. So basically, this assisted in data entry in this system that we had. So as I mentioned, the pre-post implementation study was basically to examine the integration of digital and mobile techniques compared to the current paper-based system that we have, where forms are filled by the different officers, then these are transported back to the main CRVS center, then input to the central integration system that we have. So we are looking at how best to improve this so that we have timely and quality data. So interventions, we had the digital form, which is the official notification form, digitized. So then each officers were trained for data entry and archiving. So this was done prior to the data collection. Then our main focus was to go back to work on the backlog. So we went as far as 2021. So the process was more of, as the backlogged forms were being entered into the system, also current dates were also notified in the system. So our in the analysis bit, we were looking at completeness, timeliness, and data quality, where completeness was defined as total notified over the total number of deaths. And then timeliness was considered the date which the death occurred to the date the notifications are notified. And this was all done in R distribution test and reported with different CIs. So as you look on your screen, that is the snapshot of a dashboard. As I mentioned, the additional key feature that we had was the creation of the dashboard. This was majorly to evaluate on data quality and to monitor, or rather to track data collection. So it was a real-time monitoring tool. So this enable us to know the different officers, what are the number of deaths that are streaming in. So you could filter this in terms of provinces, years, the districts, depending on what you want to access. And also this enable us to support analysis. So this is just a snapshot of the summaries that we had on the dashboard. Going on to our results, between the period that we were piloting, that was January 2021 to around 2025 June, we had around approximately 115K death captured. And just a summary of what we were seeing on the data is we have approximately 60% of male being reported with a mean age at death of around 40. Then the highest mortality was seen in children under 1. And of course, Lusaka had the majority of the deaths that were reported in this system. Then looking at the system, as I mentioned, we're comparing between what was being done in the e-notification vis-a-vis the manual paper-based system that is currently on. So looking at it, the electronic system captured a significant increase of data, more deaths than the manual, with around a chi-square of around 4. Then the completeness improved by to around 17 compared to the 11 that was seen in the paper-based system. Then the timeliness, on average, it improved by 50%, where we could see using the manual data set, it was around 6 days. Then with the e-notification, it moved down to around 3 days. And we could see completing a form really improved. So a form could be completed within 5 minutes of the notification. Then into the discussions, looking at the impact of this study compared to the CRVS performance, we compared this and we saw that our results were really comparing with those of Papua New Guinea and Tanzania. So they're also looking at mobile-based notification systems, and we will see the improvements in terms of completeness and timeliness were really matching to the same. Then I think the dashboard, the automatic checks that improve the quality of data that we are streaming in. Then on scalability, given that this, I'm not sure if I mentioned that, the e-notifications was done on Kobo form, which is an open source and free. So the open source platform could really be a game changer in terms of governments in cost effectiveness, national scale bit of it. Then this will also reduce vendor locking and so. And this model can be really extended to other LMICs. On limitations, as I mentioned, it only covered in 4 provinces. So probably increasing coverage of this e-notification will improve or rather give more information on the notifications bit of it. Then this system hasn't been integrated in the national INRIS platform. So integrating this will also improve the notifications and registration of the deaths that are being reported in the community. I mean, in the community vis-a-vis the facility. Then this will also improve the limitations. We miss some of the community deaths, as my colleagues have mentioned. Of course, the challenges are similar across different LMICs. Then on the recommendations, as I mentioned, this platform has not been integrated the main central government system. I think that is something that could recommend integrating to the digital platform could really improve registration, notification and registration as large. Then probably have a long-term cost effectiveness of moving from a paper-based to digital, how that will improve the notification system and such. Then on community-based data surveillance, as my colleagues have said, the challenge of different, probably the village elders, the CHVs. So if you strengthen these links between how to capture the community deaths and collaboration with the local councils, burial offices, and the national agency, then this will be key to improve notifications and registration. And lastly, but not least, I think it's key that we institutionalize the cross-sector collaboration. So different agencies to collaborate, such as local councils, the DNRPC, and MOH as large. Thank you.
Thank you, Esther. It's great to see the improvements with having an electronic system for that. And the institutionalization and cross-sector collaboration, I think that's something we've heard across the panel, and also trying to figure out how to reach people in rural areas or populations that aren't living in major cities. Are there any questions for Esther?
Sorry, we have one from Bashka. Bashka, I don't know if you want to turn on your microphone, or I can read it out for now. So Bashka Mishra from UNICEF is asking, what are the plans to convert these e-notifications into registrations?
Yeah, so as I mentioned, plans are ongoing on integrating the e-platform, or rather the e-notifications that are filled in the e-notification system to the central INRIS. So INRIS is the government system that is currently there. So plans are ongoing to integrate these two. So once we have the notifications done in the e-notifications and integrated to the INRIS, then we can be able to register this fully.
Yes, in the back of the room, and then we'll come up to this middle table.
Thank you, Esther, for that wonderful presentation. Just out of curiosity, I loved your statistic that most of deaths were seen from Lusaka registrations. However, would you think of that being maybe a lot of people, since Lusaka is the capital, maybe a lot of people go to Lusaka seeking for better health care from other regions or other provinces, and that's what making Lusaka proportion to shoot. That would be something maybe you can think of. And another thing, I don't know whether there are some kind of mixed methods that have been done in Lusaka concerning civil registrations reportings. Maybe is that something you can recommend for further research, maybe to integrate people's perception and acceptability? Thank you.
Yeah, sure. Thanks for the question. Yeah, definitely Lusaka will say it's kind of metropolitan in a way. So of course we expect different notifications coming from the different provinces as such, but I wouldn't say really it's okay. The numbers could be boosting because of that, but then in the different notifications that we have, I think they usually like fill the provinces that they come from or where the provinces of death, the death occurred. So I think that is I don't have the summary of the dashboard, but yeah, so that could really explain in the dashboard. You could see the different dates of it. And yeah, I could say the numbers increase because of the different people that are streaming in. And then on the mixed methods, you are right, more analysis and exploration of this data could be done. Currently, I think our main aim as a start was to see, does this notification that has been introduced within that period, is it really having an impact on the number of notifications that are done in the country or the provinces that we piloted in? So yeah, we could further explore the data set and have more analysis to give a clear picture of what is happening in the community or rather the provinces. Over.
Thank you. I just have one question. As I understand, there are two systems, parallel systems, one paper-based and one digital. So, so that I see that the data entry operator can choose one of the systems. So, can there be duplication of data entry or either miss the data entries with using this? Can there be confusion with these two entries parallelly operating together?
Yeah, you're right. Duplication is likely to happen. And as I mentioned, since we were piloting this system, we wanted to see, is it best to have the digital system in the different facilities and barrier sites that we have? And as you mentioned, once integration happens, they are more likely to have duplication in it. But then our main focus is to, or rather what is happening in the facilities and burial. Of course, there's the bit where they fill the e-notification system and together with the Form 13 as a hard copy. So when we say it's manual towards the other system, in a case where for them, they fill the hard copy or the paper form base, but then it takes a while before it reaches to the central offices where they fill into the existing system. So for now that we know that the e-notification improves this, it will be more of once we integrate these two systems, then that will, the duplication bit will be avoided. But currently as it is, there are high chances of having duplicates in both systems.
All right, great. Time for one more question. Yes.
Morning, everyone. My question is related to, the Kobo toolbox. So Kobo toolbox, as you know, is an open source software. So how are you ensuring data privacy of sensitive mortality records when using such open source platforms for community surveillance in your country? Thank you.
Thank you for the question. I think I wouldn't say I have an answer straight to an answer. I could pass it over to our IT personnel.
Yeah, morning. My name is Odhiambo Collins. I'm the software engineer for the project. So Kobo is open source, yes. And because this is government-led project, we installed it in the government servers. And we are working alongside the Ministry of Home Affairs, ICT, to make sure that the data is secured. And the ministry actually provided tablets with username and passwords. So nobody can access those tablets except those registration assistants. So that's how we approached it from that side. Thank you.
Thank you.
All right, great. Thank you. We'll hold on questions, but please write it down and save it for the Q&A at the end of the session. We have our final presentation on the Cook Islands with Mina. So I'll hand it over to her to talk us through MedTech evolution and death information documentation.
Good morning. My name is Maina Mateo. My research topic is clinicians' utilization of MedTech evolution, a database system for death documentation on Rorotonga in the Ministry of Health, Cook Islands. I would like to sincerely appreciate to the Secretary of Health in the Cook Islands for allowing me to do this survey. and to the clinicians for their valuable participation, and to the Health Information Systems team support. To the CRV, CAT, mentors, colleagues for their guidance, and also to the ESCAP, ECA, Bloomberg, and SPC for all the support for both technical and funding. Cook Islands, with a population of about 7,000 across 15 islands, as a centralized health system based on the main island of Rarotonga. The study was conducted at the hospital and primary health care, involving medical doctors responsible for their certification. Data systems called MedTech Evolution is used for patient management and death information documentation. The study purpose is to assess the clinician's use of MedTech Evolution for death information documentation and to evaluate the completion and consistency of data entry across the required fields in MedTech Evolution. The research methodologies. A cross-sectional survey was conducted among medical doctors at Rarotonga Hospital and Primary Healthcare Center, with 14 out of 20 clinicians who participated in the survey. Data were collected through questionnaire, communicated to participants through email, sending the questionnaire with information sheets, phone calls, and in person. The timeline given to the doctors responding was 2 weeks, and analyzing using Excel with support of the HRIS systems. Ethical approval was obtained from the Secretary of Health. The key areas, as you can see on the graphs, is there are 4 sections in my area, but these are the 2 areas that I collected, the challenges and the areas of improvement when it's part of the questionnaire in the survey. The discussions. Key challenges were identified, including the lack of training, internet connectivity issue, and time-consuming competing other clinical duties affecting documentation. And also improving areas highlighted the need for more training, additional support, and system enhancement and better template. Overall, strengthening capacity and system performance is important to clinicians. The implication of the study says strengthening clinicians' capacity in MedTech is very important. To improve documentation practices, current inconsistent and incomplete entries affect the quality and reliability of mortality data. Key recommendations: provide regular training and refresher sessions to strengthen clinicians' use of MedTech Evolution, internet reliability, and systems to ensure smooth operation. Developing standard operation procedures, data entry guidelines, and workflow charts to standardize processes. The next step, to finalize the project report and complete the final draft. Disseminate findings through fact sheets summarizing key results. And develop a policy pre-paper and present key recommendations to the Ministry of Health executives, which I have the great privilege through the Secretary of Health and including my director and manager in knowing what I am doing in the project as part of my workload in my current job. Thank you, everyone, for listening.
All right, great, thank you. And while people are thinking of questions, in one of your slides, you noted that it looked like the highest area for improvement was more training.
Yes.
So did you find that the doctors are requesting more training rather than having technological or system issues? That was a higher priority?
Thank you for the question. Why I mentioned more training, because working in this space as in the health systems informations, I found out also there were some doctors, new doctors coming on board and doctors leaving. So there is no, the question is, were they given any training to the new doctors coming on board? A proper training, knowing what's the systems from A on our MedTech information system is the daily notes. And there are some query fields in the MedTech which the doctor should be able to complete it in order to have that completion of data entry for the dead patients. So it's changing of, like changing of doctors, some doctors leaving and new doctors coming up. So in Haynes, when I did my recommendations around, I found out we have a training manual, but it's not specifically around death. It's just a journal. So in this survey, I find out there's a need that this is only one issue, death. There are other issues in with this. There need to be a specific SOP needed to be developed, and operational flowchart is also important for this in order to complete. Because working in this space also, I have also alluded and working closely with the chief medical officer who is responsible for the doctors entering that these are the missing gap that they need to come up with something. So that's why hence I take it on as my survey, so I can have that solid information and with numbers as an evidence when I present to the executives what's been happening, and they may be able to support trainings, not only just currently for future trainings within probably twice a year because of the transition of staff within our ministry.
Okay, great. Thank you. So turnover was an issue, and that's why the training is needed. Yes, we'll go here and then to this table.
Thank you very much for your presentation. I would like to learn from you about just what is MedTech and what do you mean by death information documentation? Is this MCCD or what training, what specific training needed? Training for filling the MCCD form or what else? Yeah.
Thank you for the question, including that, because some of the doctors, new doctors, are not aware about the ICD-10. Also, on our mid-tech evolution, it's not in compatibility. So us HIS team is doing manually. What I mean in completing means, as usual, when a doctor attend a patient, for example, this one, the daily notes, enter it. But there are other queries like classification, screening, where they need also to enter it. But we found out as a health information systems, because we are the ones collecting this report and doing it weekly and monthly, that we found out some queries, structural queries in MedTech are not being filled per patient entry. So ICD is 10 is something else that us the team are doing it manual. It's not compatibly. So our hoping is not only part from this, there's a lot of more discussion around it where we may be able, because I've been asking that ICD-10 to be compatible into the system would make it even better for the doctors to enter into it. So all we need to do is, because I attended a workshop last year, and I understand some of the countries probably around here, at the hospital, there's people who are coders, hospital coders, but not so in the Cook Islands. We don't have like a hospital coders or primary healthcare coders. Those people would just maintain, that's their job. Back home in the Cook Islands, health information system staff are doing it all for the ministry. That's my team. Me and my team is doing. So this is a starting point where other issues will be added on to make it credibility and also as an evidence base. And also for us, the staff that I see it's adding more, it's a bit of challenge. But I'm so thankful about it that into this way, there are more things that needed to be added on to be aware, not just only to our management team and other management team also within the ministry. So we can all work together to support it, because reporting is very important. At the end of the day, we are the collecting of the data and we make the report. And we know what are the challenges that hasn't been filled as is supposed to complete the entry onto the MidTech for each patient, especially in this survey from the clinicians. This is we're talking about clinicians. There are other issues around the nurses too, that they are not completing their part too. But focusing on this as open also another I added more to. But I'm not going to dwell on that, but based on my research around that. Thank you.
Okay, wonderful. So MedTech is the software you use to
Yes.
put death information in the system, and you're finding an issue with it being completed fully.
Yeah.
So the training would help to ensure comprehensive data so that
Yes.
you have that information on deaths.
Thank you.
Oh, sorry, I said we'd go to this table and then we'll come up to Chloe.
Thank you. I'm Reza from Maldives. I had a similar question that was asked before, trying to understand what medtech was and the kind of training. My question is regarding, since of its challenges and its improvements, you have highlighted training a lot. So I was wondering, when you did this study, for the study participants, were they trained for the medtech before doing the study, or was there a group that did participate in the study without having prior knowledge of doing the entry into the medtech also? And apart from the challenges that's highlighted here, I'm just wondering whether any other challenge was there in terms of missing documentation that became an issue as such, which came up in the study. Yeah, thank you.
Okay, so I hear your question of, was there a control group or a group of doctors who hadn't worked in medtech before, so you could compare the previous doctors with the new doctors who were trained? And then the second question was related to missing information, if you experienced that during your study.
Thank you for the question. I am not sure the background of the doctors coming, the new ones coming into our ministry, whether they have been aware about that as our database. But to me, I really like to strengthen whoever comes in to have that proper induction training program. We may have it, but not in a fully of pretty like 1, 2, and 3. Press here, press there, press there. Instead of, okay, there's the system there. All you have to blah blah blah. I'm not sure about the doctors in here. Sorry if I have some words. But from I'm not sure how well the new doctors were trained into really going into the systems itself, including not only with this training is our team and also the IT. IT people is also important because they're the ones who develop so this is in a way, because one of the response in the questionnaire is better template for them. So this is like looking at across the board where we can sit down together with the management of the clinicians team, including the IT. Where best can we, what is it, better template, or how best can we do this? In our medtech, the queries are there. They only need to go for example, classifications, where the death occurs. On the death certificate, we know about the death certificate, well, everything is, but that's only a snapshot of it. But in the database itself, there's a whole lot more to enter, to complete it. Because as a HIS team, we're the ones at the end of the tunnel, collecting it and marrying it, whether this is sometimes, because daily notes, we don't go there and extract it. And then like, how many days this week, this month, how many, so we don't extract, but we do go back there to ensure whether this data correlate with this one on the daily notes. So, and also there is some inconsistency around it. So there is some gaps, challenges that I'm wanting to improve around in order for the benefits of our team, the HRS team, to have that work flowly, because this is only one of it. This is only, if I may allude it also further into it, we have our weekly reporting and also our monthly reporting, which the HRS team is doing our Ministry of Works reports. Yeah, thank you.
Thanks, Mina, for the excellent presentation. And I really liked what you just said at the end there about the whole purpose of this research is to improve the operational functioning of your team and to make everybody's jobs easier. So I know you're representing the Ministry of Health, but I keep seeing on LinkedIn the wonderful news that the Ministry of Justice has just implemented a new open source digital CRVS system. So I was wondering if you could perhaps tell us a bit about how medtech may be connected to this CRVS system and if there are plans already in place for that?
Thank you for that question. I wanted to see if there's a lady from SPC, but probably she's not here. Thank you for that question. And it's been just open recently, I think last month, for the CRV, that system. That is between Ministry of Justice and Ministry of Health. The MedTech evolution is different. So MedTech is our database, MOH. So only doctors are allowed to enter into that. And that, when I saw it, that's which is very good to enter all what is it. And I'm hoping, because this is just a baby last month, it's like a kindergarten last month. So we'll see how in the few months, what it's going to be like, because they will be filling two on the open CRV and also to the system. So I was in the training when we, not really a train, probably it's a sort of a training, but it was only for the doctors to enter into the CRV, none of us. So I see us as a HIS team. Okay, the question is, where are we gonna get that data in order to marry? And they said, okay, because the Ministry of Justice is the one who's operating behind it. So all we need to do, which we have been working together with them. So when we request for the data to correlate what we have, so whether it's Mary or what, so their request is also, it's still continue as it is, that we will be able to ask from them the data, what's been up there in the open CRVS, and what's in our MedTech system. It will be interesting. To me, it's gonna be interesting whether the doctor has entered both the MOH database, the MedTech evolution, and this one. So hoping by in a couple of months, we'll see how it goes, the system is. But it's a thankful privileges for us in there. So I find it also, it's a privilege from the SPC. Thank you so much, SPC, for doing that, because it will make it also easier to me that for the doctors to enter that, and also for the Ministry of Health to enter that. Why? The reason is we all know about death registration. From here, in the Cook Islands, it has to be within 3 days that a person must be registered. For the birth, within 14 days. But for the death, so it will make it even better how best they're going to register into the system faster. So hoping in the near future, our data will be able to marry in 90% instead of 70 or 80%. So yeah, that's the way forward. Thank you.
All right, great. And I hear clapping. We can go ahead and clap for the whole panel. That's great. Thank you all for very interesting presentations, and it sounds like there might even be new study ideas in the future as new systems changes occur in various countries. So now we have our open Q&A. You can ask questions to any of the panelists, or if you have a broad question that you'd like to hear from a few panelists, we're open to that as well. So please feel free to go ahead and raise your hands. Yep.
My first question will be directed to the presenters from Zimbabwe. Zimbabwe, I think, is a very practical presentation which cover more of the practical, problems that are which we normally encounter in the developing countries. I think if I'm not mistaken, just now that you mentioned there about still less than 50% of death registrations were reported, right? And then whatever the problems that you mentioned are very typical to developing countries. And I think that before you even start the digitizations of your system, I think you still have to put a system in place, whether it is manual based or whatever. This is what I experienced a long time ago, in my country. So one is in place, then straight away when your ICT comes in, your whatever facilities available, then you can straight away convert it and let it move on. The second question is to Zambia. I think you presented a very good models, for the platform to digitize these civil registration systems. If I give the impression that you have started for the whole district, right? And then maybe extending up to the national levels. So you are taking a longitudinal approach, one district when it's perfected, and then you going to replicate in other districts But there are two approaches to it. Some countries, they use these type of systems, but it takes a long time. You start from the peripheral levels right up to the country for a particular districts. Then you go by districts. Normally, it's very time consuming. And the other alternative approach, which I experienced, is that you go by levels, maybe from district level to state level, national levels. And that from there, then you start going down, when all the facilities are in place at the peripheral levels and from the district level onwards with all the trained personnel. So I don't know whether you have any plan to start moving on, which approach that you are going to adopt. Thank you.
Thank you so much for that. Yes, so Zimbabwe has started the digitalization process, and we believe that once the systems are digitalized, everything else will be integrated within the system, and all the other interventions, I believe, will be easy to just link with the system. So thank you so much.
Yeah, I think you're right. So basically, the approach that we used to were looking at the provinces with high mortality rate first. As we move to see if it's working, then scale that to a national bit. But as the suggestion or the the approaches that you've suggested, I think they're also a good idea. And I will say at this point, if we have a particular plan on and taking any of those approaches, because currently, as we've started with the high mortality provinces, then I think we need to recycle back to see what's the best approaches to implement that. Over.
Okay, mine are comments just to presenters from Zambia and Zimbabwe. You talked about e-death notification system, but after hearing what you have been said, it is as if the notification is something that is apart from the registration. Yet the notification is just the beginning of registration process. What you have to have in mind is that the system should be one, having the notification and the registration in the same instance or in the same place. This is the idea that we have to have in mind and the concept that we have to have in mind. Second, it's about Zimbabwe. They talked about nurses providing causes of death. I think you have to think about verbal autopsy and not the MCCD, because medical doctors are the one that may provide the cause of death, while nurses or other persons may help in providing probable causes of death. Another thing that we have to have as the foundation of everything is the legal instrument. First, we may be thinking about good things, but the foundation of everything is the legal instrument. You have to have in mind that also. Thank you very much.
Thank you.
Thank you. And you're right on the bit of notification and registration. So as I mentioned, it was supporting only the notification. Then now that comes to the recommendation that I said, integrating that with the national system. So once that is integrated now, it will simplify the notifications to the registration bit. I think my colleague can shed further light on it.
Yeah, thank you for that. And I think your second point kind of also answers the question partially, the legal mandate. So you find that as Dr. Chanda there can also explain to you, Zambia has a lot of stringent laws. So we are coming from a point where this form has to be signed physically by that person, transferred physically to be signed by another person. So, and this model, we are trying to show them that you can sign digitally and transfer the same digital mandate to another person digitally. So we are trying to prove that model so that they can also see it works, because it's causing a lot of delays. As you've noticed, even the recent vital statistics report is for 2022. Why? Because that is the only data available in the system. 2023 is not even entered because of all these stringent measures. And you could see with our e-notification, we're able to capture way past 2020 to 23, 24. So it's a model, and as you say, it's true, they're supposed to be integrated. So right now, what we did with the effort is that we brought together all the through Bloomberg support, we brought together all the stakeholders. I think it was around last year, December. And we're now trying to discuss on ways on how do we incorporate digital signatures so that when somebody enters the data from the local council point of view, maybe from the lowest local government, and the data goes into the system, can they log in and just approve and digitally sign so that it cuts off this time of signatures? Yeah, thank you.
All right, great. Thank you. We have a question online, and maybe we could start with Chen Li in response, and then if other panelists would also like to provide responses, we can go down the table. From Bangladesh perspective, how can countries strengthen timely and complete death registration, including cause of death data, through digital CRVS integration with health systems, while ensuring data quality, privacy, and inclusion of rural and marginalized populations? So basically, how can other countries improve systems while also taking into account vulnerable and underrepresented communities?
From my side, I think maybe we should need a lot of efforts, such as um, human resources and the financial resources. Yeah, because in China we have all many provinces like Gansu or Xinjiang or any other poor provinces. They lack of human resources, and they also have high underreport rates, and they are working on it. So there are different the inequities of different provinces are very common in China. So maybe we should put more work, more forward in that. That's my question. That's my solution, but it's not adapted to all countries because we do what we can do. Yeah, and for another question, for another solution, I think maybe we should put more attention on it. Like vital strategies have for invest us in more than 10 years. So the CRV system performance in Shanghai has increased into a high level. So we need more support from CART, advanced strategies support. So that's the solution. Like us gathering in this meeting room, that's another solution of how to enhance the whole service system performance. Yeah, that's my question.
Great, thank you. So more resources and attention, which I think we can all agree on that. And then do other panelists have thoughts they'd like to share? I see Norman, go ahead.
Yes. So I think in order for us to improve the service systems, there is need for us to have more, maybe a collaborative approach so that at least we don't work in silos, because the solutions that we are looking for, others have already implemented it. And so that collaboration between stakeholders within the same countries, different countries, that helps. And then there is a lot of maybe systems development for us to be able to develop simple systems that are able to speak to and address local needs. most of our systems are too sophisticated that in their sophistication, they leave out the most vulnerable that they are meant to count and to include. So if we are to come up with local driven, simple systems that will be able to capture everyone, and systems that could be sustainable beyond even the withdrawal of funding, the withdrawal of donors and stuff like that, that could also help. And maybe if we work with our governments to develop legal instruments like what different colleagues have been talking about, there's need for us to develop legal instruments that supports the integration of systems, as well as that enable maybe the collaborative approach as we try to strengthen our civil registration and vital statistics systems. Thank you.
Yeah, I agree with you. We need to develop systems that are that we can own, so that are locally made. And so for us to ensure that people in the rural areas are also accounted for, we could rely on the USSD like we do for mobile money, where every corner of the country people are able to send money and receive money. So we can learn from those technologies and adapt.
For me, my experience around, I think one of the issues that I've touched in my presentation is operationally, because we're wanting to, at the end of the day, to have a quality data. Reliability and quality data is very important. So the question is, how will we be able to work around this? For me, that's why one of my issue is operational work chart, flow chart, I think is also is important. Simple, which the clinicians, for my areas, which the clinicians will flow through from point A to Z in order to complete really what they need to complete it in that. Because in getting all this data, that's why us HIS team, when I found out about these challenges, there's something missing here. Operationally, how best they can be able to enter, press 1 button, enter, press 2 button, enter, press 3 button in order to complete that. Where is it? How best? And also the transition of staff. Probably also there is a need around refresher training within 6, dependable on ministries or countries, to have that refresher trainings to the clinicians around how best they can do, to remind them. And also to me as in the management team, my job is to remind my staff, you need to do this, you need to do this, and then showing them. In the Kukarans also, we have this ongoing program. We do have every Friday. We call it CPD, continuous professional developments, that's been given to the management team around all the directorate, what you have to do for your staff in places of work, to find some things, gaps and challenges in order to improve around what is it. And from there also, let other management team that's the issue correlated with. See, for example, my one that I've been working closely with the chief medical officer in relating to the doctors. And I also alluded him in my survey before I do this. And he was so supportive, because the reason being, at the end of the day, we are the ones collecting the data, and we know where is the inconsistency about it. It's down to earth. Operational flowchart, I think, is also another step to develop. Thank you.
Great, thank you. A lot of good ideas. Additional questions in the room will come up here and then back into that table.
Thank you, presenters. I think this is a quite interesting discussion. But the more it goes on, the more I get worried, because we've sat here and talked about digitalization. Both from the presenters and the audience have not had one word, AI. Where does it sit in all this? Where can we have we thought about it? And this can be anyone, doesn't have to be the presenters. Anyone in the audience can also talk about it. It's with us, it's here, and there are solutions, it's something. So I don't know whether anyone has thought about how do we employ it? How do we bring it into this to ease our work? And what would be the implication? Thank you.
All right, great. We love a thought-provoking question. Any feedback from the panel on artificial intelligence and AI?
if I may share, just discuss something smaller here with the colleagues. Yeah, AI, because it's the new invention of today. We were just discussing around here. Like setting our SOP and then asking AI, can you simplify it to according to the local context for Kukalin people to understand? Simple English, simple what? From A to Z. There you go. But we don't, to me, I don't have to rely on it, but I type it or everything that is coming in my head and put it on, and with the doctors, with the management team, for the clinicians to have, they say, yes, Maina. So put it in, and the AI come, wow, and I said, okay, I think that is it. That's all I can help. Thank you.
As you mentioned, AI, Shanghai has now, we are now developing an AI agent. We collected the EMR, from his medical history records, and to train their AI agents, and we also use their ICD-10 tablets and put inside to train them, and we will validate. So we want to get the AI agent as like when we put all the medical histories, and the AI will give us directly the death sequence and the underlying cause of death. That we are working on it. But maybe later we will be replaced by AI. We don't know. For now, we just want to release the working load of their physicians, especially the clinical medical doctors. Yeah.
Okay, great. And I know our team focuses quite a bit on AI is not a magic solution. So I know everyone's really excited about AI and there are a lot of benefits and uses for it, but you still have to look at what currently exists and how to beneficially use it in your current system. So there are a lot of steps to consider before fully, using AI for various systems. So we would come to this table and then we have one more question here, and then we might have to wrap up. I'll keep an eye on time. Go ahead.
Thank you, Madam Moderator. Uh, in collection of mortality statistics, there are two very useful tools. There are two very useful tools to collect mortality statistics, implemented by WHO. One of them is ANA-OED, and the other one is Doris, right? So in all the presentations I've observed, there was no mention about these two tools. But actually, these two tools will ensure good quality and high speed kind of data in terms of mortality statistics. That was not mentioned. So I was wondering whether the presenters who presented today had actually utilized those two tools rather than having what is in our hand and moving on to AI, which is something different. So why don't we just use these two tools, especially for developing countries and underdeveloped countries, to use these tools to, to collect the data more accurately, more faster, and leaving AI later for a later stage, maybe for more developed countries like China, where they use EMR systems, and then they can use AI to and your agents to collect data. So that is basically the problem. I was just trying to correlate the presentation with these two tools, which were not mentioned at all. So that is my concern. Thank you.
Great, thank you. So your question is around Doris and Anacod, and if anyone on the panel has used the tools or if your countries are using them for the processes.
Yeah, you mentioned the Doris and the code. That's not for clinical doctors. That's for the ICD coders. What we want to do is from the very beginning, when the medical doctor, certifying the death, and they don't know the ICD rules, and they even usually they just write the symptoms such as failure, heart failure, like etc. So we think training several rounds of training always didn't settle all the problems. So we want to start from the very beginning. So we gathering the medical histories and the primary complaints of the patients, and we use the not structure, just the Chinese letters, Chinese languages, long word sentences, and then it's unstructured languages. So we just use these languages input in the AI methods, and then the AI just output the structured death sequence, and the ICT can underline cause of deaths. So maybe that will relieve the CDC workers' workload, yeah, and enhance our quality. So that's why we use AI. We're trying to use AI. Yeah, that's all my question.
Any final comments about Doris or Iris before we go to our final question? Okay, I think we had one more question. Okay, go ahead.
Yes, so I can comment for Zambia. So the reason why we did not mention it on this first phase of the project is because right now, Zambia DNRPC, they have a department for coding unit. So that coding unit over the years, they've used Iris. And is it last year, recently, they were trained on Doris. So they're now at the early stages of implementing Doris. So the main idea that we were trying to tell them is that if you have the e-notification data coming in, you can run this data as a batch, either through Doris or Iris. And because right now, as we speak, most of the processes in Iris are manual. So you find that the coders are sitting and they have to code one date at a time. So we are trying to digitize also that process so that when data is coming in from the e-death notification, you can run it as a batch and then you have quick coding. So I can say the Doris is in early stages because the team there has been trained. And I think they even attended the last year's WHO workshop for training on the Doris. And then number two, when they are done with Iris, they usually go to the next step of quality checks. They use code edit and anacode before they produce the vital statistics. So the coding unit at DNRPC, they are trained on both anacode and the code edit. The only thing we're trying to do is just to help them digitize so that it's a bit faster and they run as a batch. Yeah.
All right, great. Thanks. We'll have one final question and then we'll wrap up the session. Was there a question over here? I think I saw. Okay, we'll go over to Mira. You had a question, right? Great, thank you for highlighting that. So she was just saying that there are sessions this afternoon that are more focused on coding and technology, where you might hear more about Doris, Iris, and various systems. All right. Well, I think we can begin wrapping up then, because next we have lunch, and we do not want to keep you from your lunch time. And yesterday we talked a bit about barriers and system strengthening, and there were questions that came up yesterday around digitization, and also presentations around community leaders. And I think that today's panelists did a really great job of giving concrete examples of digitization and how we can continue to strengthen systems using technology. But I really liked what Norman said, that sometimes we can create sophisticated systems and we can overcomplicate things and unintentionally leave people out. So I think it's important to focus on collaboration and leveraging systems that work, as well as the local expertise and community leaders when possible. So those were some of the takeaways that I heard from the session. And please feel free to find our panelists, continue the discussion, and I hope you have a great lunch and enjoy the rest of the forum. Thank you all.